Muito bom dia. Pedimos a todas e a todos a gentileza de tomarem seus assentos. Good morning. We kindly ask you to take your seats. Calma, ainda não começou. Muito bom dia. Sejam todos bem-vindos ao segundo dia da Conferência dos Institutos Nacionais de Saúde do G20. Em nome da Fiocruz, da IANPHI e do CDC África, agradecemos a todas as pessoas aqui presentes e as que nos assistem virtualmente. Nesse segundo dia, contaremos com 2 painéis, um dedicado à equidade e saúde e o outro que abordará a resiliência dos sistemas de saúde. Iniciaremos o dia de trabalho com o painel 3, Equidade em Saúde, que terá duração de 2h30 com um intervalo para café. Ao final do painel, faremos uma pausa para o almoço, quando retomaremos as atividades com o painel 4 sobre sistemas de saúde resilientes. Em ambos os painéis, haverá espaço para debate, com intervenções, comentários e sugestões. Portanto, pedimos àqueles que desejarem participar que se manifestem oportunamente para que o microfone chegue em suas mãos. Encerraremos o dia com uma sessão final, composta pelos coordenadores e relatores, para apresentar as principais conclusões que comporão o relatório final e a declaração da conferência. Lembramos que amanhã teremos a visita opcional ao campus principal da Fiocruz, com saída do hotel programada para as 13 horas e retorno às 16 horas. Pedimos aos interessados que se inscrevam para essa atividade na secretaria do evento, localizada no Salão Mar Azul, ou com nossas recepcionistas. Pedimos, por gentileza, que mantenham em modo silencioso os seus dispositivos eletrônicos e celulares. Para darmos início ao painel 3, cujo título é Equidade e Saúde, convidamos ao palco a doutora Shelley Breton, líder do Programa do Instituto Nacional de Saúde do CDC dos Estados Unidos, que será nossa coordenadora. Por favor, doutora Shelley. Convidamos nosso relator, Dr. Félix Rosenberg, da Fiocruz, e coordenador da Rede Latino-Americana de Institutos da IANPHI. Dando prosseguimento à composição do painel, temos a satisfação de convidar nossos panelistas. Dr. Raji Tajuddin, chefe da Divisão dos Institutos de Saúde Pública e Pesquisa do CDC África. Dr. Félix Rosenberg, que já está conosco, nosso relator da Fiocruz. Doutora Karen Hacker, diretora do Centro Nacional para a Prevenção de Doenças Crônicas e Promoção da Saúde do CDC dos Estados Unidos. Dr. Pierre Gerlier Forret, presidente do Instituto Nacional de Saúde Pública de Quebec, Canadá. Doutora Stéphanie van der Toren, coordenadora do Programa de Desigualdade Social da Agência Francesa de Saúde Pública. E Dr. Shiva Muruga Sampillai, conselheiro sênior do Instituto Nacional de Saúde do Zimbábue. Por favor, doutora Shelley, queira proferir suas palavras introdutórias e assumir o painel 3.
So, good morning, everyone. I hope that you have recovered from the meat coma from last night. A huge thank you to Fiocruz and IANPHI for a wonderful evening. It was much enjoyed. So I'm really happy to be part of this panel this morning. As mentioned, I'm Shelley Bratton, and I lead CDC's National Public Health Institute program. I'm also the co-chair of IANPHI's Committee on Social and Public Health Inequalities. And equity really is cross-cutting. We heard it come up in every session yesterday. In the 2021 Rio De Janeiro statement, IANPHI urges member organizations to place the promotion of health equity in all the work that they do through dedicated surveillance, tracking progress, and working with decision makers to prioritize addressing health inequities. During the session, we're going to hear from the panelists about their agency's work in this area. And we'd really like to have a robust discussion to hear your ideas on health equity and what we should see in the final statement coming out of this meeting. So we're going to jump right in. Our first speaker is Dr. Tajuddin, the Acting Deputy Director of Africa CDC, who will speak about structural inequities in Africa. Taj.
Good morning, colleagues, ladies and gentlemen. I've been asked to talk about Africa CDC experience dealing with structural inequality in health in Africa. So, colleagues, ladies and gentlemen, if you take a step back and you look at the COVID-19 pandemic, you will realize that the most spoken word is equity in the course of responding to that COVID-19 pandemic. But the big question is, why did it take us so long, the COVID-19 pandemic, so many deaths, to remind us or to lay bare the structural inequality that's always been there? Having said that, colleagues, ladies and gentlemen, the continent of Africa has 55 member states, 1.4 billion people. Today, we are a continent that has been described as syndemics, meaning that you have infectious disease, you have non-communicable disease, you have maternal, newborn, child health related issues. We also have a population that is fastly growing, and we are expected to double by the year 2050, meaning that will be 2.5 billion by 2050. Not only that, our urbanization remains largely unplanned, meaning that people just find themselves in the city. There is no, any program in place for government to take care of those people who are coming into the city. We also know that when it comes to health workforce, we are nowhere where we are supposed to be. Let's look at community health workforce. In 2017, our head of state and government gave us that mandate to train and deploy 2 million community health workers, so that for every 500 to 600 people in the continent of Africa, you have one community health worker. Today, we are far from that 2 million. we just roughly around 900 to 1 million. Let me also mention that if you look at frontline field epidemiologists, talking of people who just undergo training for 3 months, to support surveillance, emergency preparedness and response, risk community engagement at the front line. We need around 25,000 as far as the continent is concerned. Today, we have just around 5,000. If you look at the advanced field epidemiology training programs, the statistics is not anyway different. Today, we have around 2,500, and we know that to guarantee our health security as a continent, that's ratio 1 epidemiologist to 200,000 population, we have a very huge gap in that space, close to 4,500 advanced epidemiology. Let's also look at climate change. We are the one emitting or contributing to that space the least, but we are bearing the greatest, the maximum amount of issues as far as that space is concerned. We saw the way the cyclone decimated Southern Africa member state, and I'm glad my colleague Eduardo alluded to that yesterday. If you go to East Africa, it's also not different. You see flooding, you see Rift Valley fever, and so on and so forth. Let's look at AMR. We have 1 million people dying as a result of consequences of antimicrobial resistance on the continent of Africa today. And we clearly know that the drivers of AMR on the continent of Africa is different from the drivers of AMR in the global north. But what are we doing about that? And last but not the least, access, equitable access to medical countermeasures. Today, when we talk of vaccines, we import more than 90% of what is needed. Therapeutics, the same thing. Diagnostics, the same thing. Let's look at the mpox that is going on in some part of our member states, more than 13 or so of them. As of April this year, the test rate in DR Congo, the epicenter of the mpox, was just around 12%. So how do you bring an epidemic under control when your test rate is around 12%? So these are all the structural, inequity that we are seeing as far as the continent is concerned. Now, Africa CDC, your Africa CDC, what are we doing to address that? So based on all these issues that I've outlined was the reason behind the call for a new public health order. We need to begin to do things differently. We need to strengthen our public health institutions, starting with the national level, the regional level, and at the continental level. We also need to find a way to make sure that we have that access to the medical countermeasures. And this explains why our head of state and government launched the Partnership for Africa Vaccine Manufacturing. And in February this year, that particular initiative has been given expanded mandate. Now it becomes platform for harmonized African health product manufacturing so that we can address issues related to therapeutics, diagnostics, and other products. Let me also state here that in the course of responding to the COVID-19 pandemic, we did set up African Medical Supply Platform because we all know what happened in terms of vaccines. We knew what happened in terms of therapeutics, diagnostics, even some PPE equipment as simple as masks, gloves. We knew what happened. So we did put together African Medical Supply Platform at that time to ensure that each and every member state have access to the medical countermeasure, irrespective of their socio-economic status and their ability to pay. So today we have endorsement from our head of state to make sure that that become an institutional, a sort of a permanent arrangement that will allow our member state to have access to all these medical products. So they approved what we now call African Pool Procurement Mechanism, so as to address some of these equity-related issues. So let me shift gear and go to primary health care. Because if you talk of equity, I think what readily comes to mind is primary health care. And for Africa CDC and African Union, we are working with our member state to really scale up community health workforce on the continent of Africa. Not only that, the frontline field epidemiology training program is also one area we are paying a lot of attention. And of course, we know that access to primary health care is largely driven by out-of-pocket payment. And we know that more than 70% of our population, are pushed into poverty just because of health-related spending. And in that regard, our health economic and financing program are working with our member states to ensure that we have appropriate financing, especially the informal sector, at that level in the community, so that the issue of out-of-pocket payment, is no longer the order of the day. Let me also state that in terms of financing, we're working with our member state to make sure that we optimize what is available in terms of resources for health. And in this regard, Africa CDC is working towards becoming an implementing entity, part of the pandemic fund. I don't want to go into why we are not implementing entity right from outset, but we've made a lot of progress to make sure that we become an implementing entity. But even before then, we're working with a lot of member states to make sure that we submit joint proposal. Because if you leave it to each and every member state to do it on their own, a lot of our member states do not have the capacity to do that. So Africa CDC is working with them, and we have actually worked with them to make sure that we submit a regional proposal and multi-country proposal. In the course of responding to the COVID-19 pandemic, we did reach out to the MasterCard Foundation, as a continent, through our head of state and government, and that support or that request yielded $1.5 billion US dollar, and that alone allowed us to support all our member states in terms of the COVID-19 pandemic. And that support, that project called Saving Life and Livelihood, the core principle behind that is the principle of inclusion, making sure that nobody was actually left behind. Colleagues, ladies and gentlemen, the pandemic agreement has taken too long. We've learned so much as far as the COVID-19 pandemic is concerned, and for us to be able to make sure that those lessons do not go to waste, to make sure that we avoid that cycle of neglect, panic, we need to make sure that we concretize those experiences into this pandemic agreement. So Africa CDC, the African Union, want to see a pandemic agreement that is underpinned by equity and fairness. And last but not the least, Lusaka Agenda, the Future of Global Health Initiative. One country, one plan, one budget, one M&E framework that will allow our member state priority to be the fulcrum, to be the cornerpiece of whatever support that is coming into our member states also remain critical. My major ask to the G20, let's finalize this pandemic agreement. I know we can work together. African Union has come up with a common African position on that. So what we ask from you, what we beg of you is to support that common African position. Number two, WHO, Africa CDC, African Union, Agenda 2063 have all emphasized the importance of universal health care, through primary health care system. But we know that this is not possible without a social security system, without adequate financing. I think that is also a key ask. Last but not the least, social determinants of health. Let's really leverage your platform, the G20 membership, to address or to support our member states to be able to address all these social determinants of health that is driving some of these inequity, and that is also making our continent to become syndemic. Colleagues, ladies and gentlemen, let me stop here. Thank you.
Thank you, Taj, and appreciate the emphasis on access to the commodities, to the healthcare, the financing needed to not have those barriers, and also inclusion across the board within the workforce programming and with the population. We'll now move to Dr. Rosenberg with Fiocruz. Felix serves as co-chair on the IANPHI Committee on Health Inequities with myself. He is also chair of the Latin American Network of NPHIs, and he will speak with us about the intersectoral approach of the SDGs. Felix.
Thank you, Shelley, so much. Good morning to everybody. I'm going to present in English the slides, but speaking Portuguese with your kind understanding. Não vou falar muito da Fiocruz. Vou falar. Eu queria lembrar alguns conceitos básicos de inequidade e como enfrentar eles, que verdadeiros potenciais têm os nossos Institutos Nacionais de Saúde para enfrentar as inequidades. Começando por lembrar, que as inequidades em saúde podem ser definidas como aquelas diferenças na exposição a determinantes biológicos, socioeconômicos e ambientais da saúde e da doença, no gozo do direito à saúde, no acesso aos serviços de saúde, que são evitáveis e injustos e que afetam sistematicamente, e faço questão de ressaltar a palavra sistematicamente, populações frágeis e vulneráveis. Determinantes como moradia, educação, renda, água e saneamento, transporte público, esporte, cultura, lazer, não são apenas fatores causais de doenças. Eles também impedem as pessoas de desfrutar da cidadania, do bem-estar, que são os mais importantes indicadores de saúde. Diferenças sistêmicas, isto é, diferenças resilientes, permanentes, evitáveis e injustas, estão na base da estrutura social, tanto nos níveis global, nacional e local. Há cerca de 200 anos, John Snow evidenciou a determinação territorial da cólera em Londres, onde o território afetado era caracterizado, como todos sabemos, pela falta de abastecimento de água potável. Mas ele também relacionou, e os epidemiologistas esqueceram disso, que as ocupações, as profissões de baixo perfil, a diferença de até 10 vezes na mortalidade, da mortalidade por cólera. Claro que essas ocupações estavam diretamente ligadas ao território sem água. Então, todos sabemos que a ocupação, a profissão, é o principal indicador do gradiente social ou classe social, como queira chamar, ou seja, é um indicador de estrutura social. As evidências são abundantes. Durante pelo menos os últimos 70 anos, uma miríade de artigos publicados em todo o mundo, mas particularmente na América Latina e na Europa, utilizam determinantes socioeconômicos e ambientais como indicadores de risco para as mais diversas doenças e patologias, e também para as taxas de morbidade e mortalidade. As evidências sobre os determinantes estruturais da saúde e da doença são bastante abundantes. Mostrar essa relação já não é um problema, já não é o desafio. A distribuição mundial de cólera é hoje, 200 anos depois de John Snow, um retrato mapeado, um mapa do status dos ODS e das metas da Agenda 2030. As evidências existentes nos permitem medir fatores de risco para o alcance do ODS 3, o ODS das doenças, por meio do status da maioria dos outros ODS. E, reciprocamente, as metas do ODS 3 podem ser usadas como indicador do alcance das metas dos outros ODS. Portanto, equidade em saúde e bem-estar está diretamente relacionado ao alcance da maioria dos ODS. Ninguém deve ser deixado para trás. E este é o verdadeiro significado de saúde em todas as políticas. O desafio é o que podemos fazer a partir do setor saúde e especificamente dos institutos para intervir ou interferir em todas as políticas de enfrentamento das iniquidades em saúde. Nós temos algumas oportunidades no setor saúde. Melhorar o acesso equitativo aos produtos de saúde, promover o acesso universal ao serviço de saúde. A Fiocruz, o Instituto do Brasil, na sua história de 125 anos, teve uma importantíssima influência nas políticas nacionais, incluindo a participação na criação do seu Sistema Único de Saúde, o SUS, na produção de vacinas e medicamentos, kits diagnósticos para acesso público, o estabelecimento de políticas específicas para populações vulneráveis, como os indígenas e os afrodescendentes, a capacitação de profissionais e técnicos de saúde e muitas outras questões relacionadas diretamente à equidade em saúde. Mas, apesar disso, o Brasil continua sendo um país com grandes desigualdades sociais e inequidades em saúde. As inequidades só podem ser enfocadas intersetorialmente. No entanto, enfrentar mudanças resilientes, intersetoriais, que impactam nacionalmente os determinantes sociais, econômicos e ambientais de saúde e da doença, estão, em geral, fora do escopo de ação de nossas instituições. Enquanto políticas setoriais são discutidas globalmente e definidas em nível nacional, a implementação e o impacto dessas políticas serão integrados nos territórios onde as pessoas vivem. Como mostrado inicialmente por John Snow, nos primórdios da epidemiologia, territórios frágeis e vulneráveis são caracterizados por uma estrutura social frágil e vulnerável. As estratégias territoriais são mais eficientes e execuíveis. Os governos locais e municipais estão mais familiarizados com as realidades territoriais. As abordagens intersetoriais são politicamente muito mais viáveis em níveis locais. O território vai nos dizer quais são as desigualdades mais importantes. É muito importante reconhecer que nós não temos o completo domínio do que é uma inequidade em saúde, uma desigualdade percebida pela comunidade. Nós, às vezes, achamos que uma doença ou outra doença é o principal problema de inequidade numa população, quando a população o que ela quer e precisa é transporte público, por exemplo, para aceder ao serviço de saúde ou para aceder ao trabalho. Então, entender o que o território nos diz sobre inequidades é imprescindível para tomar medidas de correção. E, por último, você pode agir com um conjunto de determinantes simultaneamente se você atua sobre esses fatores de desigualdade injusta social. É muito mais fácil promover uma abordagem intersetorial das desigualdades de saúde no nível do governo local. A estrutura dos sistemas primários de saúde é provavelmente o principal trunfo para atuar sobre determinantes intersetoriais, porque a atenção primária de saúde é a abordagem de saúde e bem-estar para a participação da comunidade e não apenas a porta de entrada para a prevenção e cuidado de doenças. A atenção primária de saúde é a presença mais ampla do Estado nos territórios. Pelo menos os setores de saúde, assistência social e educação compartilham questões e desafios comuns a nível local. Então, por último, queria sugerir o papel potencial dos institutos, pelo menos os primeiros passos. Defender, em primeiro lugar, a incorporação das inequidades em saúde como área estratégica de preocupação dos institutos. Deve ser nosso primeiro desafio. O Comitê IANPHI sobre Inequidades em Saúde é uma excelente plataforma para isso. Introduzir e fortalecer as investigações sobre sistemas nacionais de saúde, no que se refere ao acesso de populações frágeis e vulneráveis a produtos de saúde e à atenção primária de saúde. Monitorar a evolução dos ODS a níveis nacionais e territorial. Construir indicadores de inequidades em saúde e bem-estar. Desenvolver projetos piloto a nível local municipal para a implementação de tecnologia social, introduzindo ferramentas qualitativas, com o objetivo de identificar a percepção de grupos sociais, culturas, gêneros e realidades territoriais específicos sobre inequidades em saúde e bem-estar, bem como as suas ideias e propostas para enfrentá-las. E, neste sentido, finalizar dizendo que, com o apoio do CDC dos Estados Unidos, a IANPHI está organizando, sob nossa guia, um projeto multicêntrico em 5 países da América Latina para aplicar exatamente esta metodologia neste preciso momento. Muito obrigado.
Thank you, Felix. And I think anyone who knows Felix knows that this topic is near and dear to his heart and the driver, a lot of what he has done, and really appreciate the reminder of one of the foundational events for public health and epidemiology and how we've watched that track over time and still demonstrate inequities and inequalities. So really appreciate that story. And also the final, that we are here on a global level and we are here thinking on a global level. But what we take home and what we do locally is how we impact our populations. So thank you for that reminder also. Okay, so moving on to our next speaker. Dr. Hacker is the director of the National Center for Chronic Disease Prevention and Health Promotion at US CDC, and she will speak about social and commercial determinants of health. Dr. Hacker.
So I think first of all, it's great to be here, and thank you so much for this wonderful panel. And I think that last speaker, Felix, did such a wonderful job of reminding us how much we all have in common, because these social determinants, which I'm going to talk a little bit about today, are very consistent in driving many health inequities, but also as we begin to think about the effective interventions. So just to give you a little bit of framework for where my center sits within the Center for Disease Control, we are the premier public health agency, or equivalent to a Ministry of Health, obviously, in the United States. And here is where the National Center for Chronic Disease Prevention and Health Promotion sits within the center. The mission of the CDC is to protect health and improve lives, and our experts do that work all the time, every day. But we also give an enormous amount of resources to the system of public health in the United States, including state health departments and local and territorial tribal organizations as well. And just to give you a sense, there are a number of us here today from CDC, and we are divided into multiple centers, as you can see here. Well, health disparities in the United States exist, and I think became particularly apparent, even though they existed long before the pandemic. But during the pandemic, it was very evident that certain populations were much more affected and that had higher level of mortality and morbidity from COVID-19. But we also know that there are a number of characteristics that really put people at risk. They bear an undue burden of chronic disease in the case of chronic diseases. And those are areas such as poverty. Turns out where you live has an enormous impact on your health outcomes due to things like housing, access, earlier was talked about access to medical care, but even job opportunities, and potentially environmental toxins, et cetera. So where you live is an enormous determinant about how you live and what your health outcomes will be. These multiple barriers are something that we are now trying to address, I think, more and more, and certainly hearing about it from our international colleagues as well. But, as Felix mentioned earlier, these are often purviews that public health doesn't really have any authority over. And so one of the themes that we are talking about in social determinants is how we work with our colleagues at so many levels, at the government level, at the local level, at the state level, to be able to really impact this work in social determinants. So To reiterate, I thought Felix did a much better job than I did in some way to explain these things, but health equity is really about everyone having a fair and just access to being able to live their healthiest lives. And social determinants are these non-medical factors that generally impact our health, and it's estimated anywhere between 50 and 80% of our health outcomes are really impacted by this variety of factors that we're surrounded by everywhere, where we work, where we play, where we worship, and that have this influence on our potential health in the future. So in 2022, we worked together at CDC to really think about a framework for thinking about social determinants of health. And we developed this with its 6 different areas of focus where we knew we had work to do, but also where we thought we could actually make some impact. And so the first is data and surveillance, and this is really making sure that we are collecting data nationally on social determinants of health, how people see their social needs, evaluating the work that gets done. One of the challenges in this arena of social determinants is actually being able to identify evidence-based practices that work and that we can recommend, in part because these take a long time. They often take multiple partnerships to actually get done. And so therefore, being able to actually point to things and being able to very directly say, it will take you X amount of time if you focus on this to actually see disparities be reduced. So that work around the evidence building and the evaluation is really critical. I already mentioned the partnerships and collaboration that's needed across so many different levels, both of government and non-governmental entities. And then, of course, the community engagement, because if communities are not identifying these as factors that they want to make a change in, it is very unlikely that you're going to see the work needed at the community level, which we often call collective action, to really bring about change, whether it's change in policy, whether it's change in pragmatic, actual physical plans, whether it's change in the health delivery system, for example. And that includes the infrastructure and capacity, which is needed to strengthen the work to be able to get this type of activity accomplished, and policy and law, because so much of what happens in social determinants, and we often hear about the political or the commercial or the structural determinants, are things that are actually embedded in our policies and laws, both policy at the big P level, but also policy at the small p level. And so we've been using this framework to move this work forward. Also, within the United States, we have the Healthy People 2030 measures, which are really our national health goals, and we started with that in our center to think about our social determinants and to specifically think about the ones that we thought we could make a difference in, at least in the National Center for Chronic Disease Prevention and Health Promotion, and we identified 5 in particular. So the built environment, which really refers to the human surroundings that influence how we live our lives, whether it's getting physical activity, for example, being able to get to a grocery store or a place where you can get affordable food. The community clinical linkages, which really speaks to how we intersect with our healthcare system from the public health side. Food and nutrition security, which just comes up over and over again in our communities. That's the access issue to nutritious and high quality food. The social connectedness, which I think is we're hearing more and more about now, how relationships drive our health, particularly as we age. And then finally, the tobacco-free policies. And as you probably know, we've been very effective in this in the United States. And I'm happy to say that we've seen over 65% reduction in cigarette smoking over the years and continue to see drops every year. As we think about what we've been doing in our own United States in terms of CDC in this arena, it does span the entire of CDC. So for example, the National Center for HIV, Viral Hepatitis, STDs, and Tuberculosis has long worked in housing, for example, to ensure that people with HIV are effectively housed, recognizing how important this is for their outcomes. In our center, 80% of the dollars we receive from our Congress actually go to the field in grants. And just to give you a sense for some of our grants, one of them is called REACH, which is Racial and Ethnic Approaches to Community Health. And that is given to local community groups, usually multi-sector partnerships that are trying to address things like food security, the built environment, and tobacco cessation. But to be able to get one of these grants, you have to demonstrate that you have populations with an undue burden of chronic disease health outcomes. We also have programs in nutrition, but none of these are actually national at this point in time, allowing states to focus on these particular areas of food security and nutritious food. And then just to mention our good health and wellness in Indian country for our Native American populations, it's so important that they're able to do culturally appropriate focus on these particular areas. And so this is a funding mechanism to be able to accomplish that. I did want to just mention that the behavioral risk factor surveillance system, which is our national surveillance system to understand chronic disease, because chronic disease is not a reportable condition in the United States. We have added a module specifically focused on social determinants that was just released, and we did small area analysis to make sure that that data was available to very local communities so that they could understand what some of the pivotal issues were affecting their populations. I just want to mention that there has been a national effort across multiple federal agencies, and then the White House actually released a playbook on the social determinants of health, which is posted online, and that really brings together this whole of government effect. We at CDC are working closely with housing, with transportation, with our agricultural departments, and with our Centers for Medicaid and Medicare, which recently made it feasible to actually get some reimbursement for social needs. And this includes screening in the healthcare delivery system for social needs for every patient. So a lot going on right now. I realize my time is up, but there's so much more to talk about. This is a very exciting area, and I am very hopeful that the G20 will take this up in the future. Thank you very much.
Thanks so much, Karen. And I think we've heard a similar theme across the three speakers this morning, this emphasis on local and community, with Taj talking about the community health workers and needing to build and expand that workforce, Felix talking about acting locally, and then what Karen just described about looking at the big picture and then determining what can we impact, what can we affect, and where she sits at CDC saying, where do I have the power to make a difference and make an impact, and then set those goals and priorities there and think through the partnerships that are necessary to make it happen. We have about 2 minutes for a question before the coffee break. So if anybody has a question specific to the three speakers that just spoke, after the coffee break, we'll come back, hear from three more, and then have an open discussion. Anybody want to raise their hand quickly and have a question? And like Meng, I'm comfortable with silence. Follow, please.
Hello. Maybe the questions should be asked after the three other presentations. My proposal,
We can do that.
I think it's much better because
Okay.
we have the
Very good.
okay?
If we have no questions, let's have a coffee break. We will come back at 10:25. We are staying on time.
Thanks.
All right? Thank you.
Como é que eu não consegui aqui?